I do want to welcome all of you here today. Now, this is actually a really exciting event because it's a whole bunch of things in one. So we're part of the Cleveland Humanities Festival, and luckily for us at this Medical History Museum, the theme this year was medicine and health, and we do a lot of that here. We do the history of it here. Today, we're also partnering with the Social Justice Institute, and as the Social Justice Institute, we've asked for panelists who can help us address some of the things we're going to be talking about today. So the part that I'm going to be delivering to you is historical. I'm going to call it "The Babes Were Silent," and this is about infant mortality in Cleveland, Ohio, particularly in the years between 1908 and 1920. Then I'm going to be asking our panelists to come up and talk to us briefly, but as always, for Dittrick Conversation events, what we're most excited to do is hear from you. So the roundtables that follow these that are public and that we want your feedback and we want to hear what you have to say and what you think about the things you've heard tonight will be open, and we're excited to do that. So let me get us started. I know Lisa's still downstairs corralling folks, but my name is Brandy Schillace, and I'm Senior Research Associate here at the Dittrick Museum, and I have a really hard time standing still, so I may move around a little bit, but I will try to be good since I'm holding on to my mic tonight. I wanted to talk about infant mortality in Cleveland because I was in the middle of a research project. And as is often the case at the Dittrick, a research project comes from an accident. You accidentally find something, and it leads you down a rabbit hole, and you find something else. So it turns out that here in Cleveland, we had someone who was a forensic expert. And as I started looking at his story, I discovered that we had a public health expert as well, named Dr. Perkins, and that Cleveland in 1908 began with about 300,000 people, and in 1920 had 1 million people. Think about that. It's an astonishing influx of people. And the more I researched, the more I discovered that some of the problems that are still with us today had their seeds planted right back in 1908 and 1910. So I want to talk a little bit about that today. Public health. You've all heard the term. You mostly probably think you know what it means, right? When I say public health, we think of things like clean water, proper sewage disposal, safe food and milk, access to care. And we think of boards of health as people who are helping to keep us healthy, but what you might not realize is previously, boards of health were really more into response than prevention. In fact, we didn't have any. We didn't have one. Then we had a cholera epidemic. So then we got one. And they tried to fix that. And then when the problem seemed to go away, they disbanded. We didn't have one again for a while. And then cholera came back, and we got another one. And that's kind of what happened. Boards of public health were not constant or permanent bodies. They were responses, in some ways, to tragedies. And I know we deal with a lot of pollution today, but in fact, we've cleaned up a lot as well. The Cuyahoga River is in much better shape than it used to be. Sewage and garbage wasn't collected at all. There were places to put it. What's one place that you think people might have put it?
Street.
Yeah, it's big and it's wet.
Lake.
In the lake, yeah. About 100 tons or something of solid waste into the lake every year. Food products, school inspections, birth and death records, these things weren't even part of their purview until 1893. We're talking almost the 20th century by then. So some of the things that we've come to take for granted in public health literally turned up at the beginning of the 20th century in their modern, permutations. And that says a lot about what we think the center of health really is. And of course, you can't have public health if you're not serving the public, right? The question then becomes, who is the public? It's a little bit like the who is my neighbor question. Who counts in these stories? So, immigration and public health go hand in hand in ways that I would not have necessarily thought. And some of this comes from, the first Board of Health was in 1832. Cleveland had 1,100 people. It's just astonishing the growth that happened in this town. The very first outbreak of cholera arrived on a steamship, the Henry Clay steamship. And of course, they hadn't quite figured out what caused cholera. So they decided it was sin. Yeah, sin was the problem. Morals, bad morals. And of course, if it arrived on a steamboat, it didn't start here, right? So who is responsible for cholera? Somebody else out there, right? So just bear that in mind, because that ends up having a lot of bearing on the way disease gets sort of constructed over the years. So why does that link between morals and disease matter? It does matter. If you think that disease is caused by bad morals, then what are you likely to think of anyone who has the disease? Not such good people, right? Who's probably more prone to get diseases? Wealthy, living off in the countryside, away from... No, not necessarily. You're getting where I'm coming from here, right? So the real trouble, though, was in the water. We were dumping things in the lake. And cholera was not spread by a miasma, and it wasn't spread by sin, and it didn't have to do with your behavior or your moral code. It was in the water. And cholera is actually it's nasty. We'll talk a little bit more about it. They sometimes refer to the people who suffered from it as the sick rose, and there's a really famous painting because you could be fine in the morning and you could be dead by dinner time, and it struck very fast. You had it in your system, but you didn't necessarily know, and you contracted it by drinking contaminated water. Typhoid was another problem, E. coli. So again, sewage removal and sewage disposal. You need to put it somewhere. There's a lot of solid waste. You've got 300,000 people in 1908, and you're going to put it in the lake or river. But we need drinking water. So we're going to get the drinking water from the lake. Right, so there's a problem. We already see that there's a problem happening here. Don't worry, they fixed it. They didn't actually stop polluting. They just got the water from further away. Yeah, we'll do that several times throughout this history. So trouble's brewing. They called it Asiatic cholera, and there's reasons for calling it that. It did originate elsewhere, and it did arrive on the shores by people who were sick in ships. But I want you to take a look at Death here. This is Death. Death is, he's just sliding into town. What's he wearing on his head? It's a fez. Yes. They were basically saying foreigner. Foreigners carrying disease from Asia, and they also meant Turkey and other places abroad. They're like, it's them, they brought it here. Now I don't know if you can tell, up here in the corner, there's a bunch of people, and they're pouring like, carbolic acid and things into the water. They're like, we're gonna stop them, like they're cannons, but they're actually like, we're gonna clean it, what were they actually pouring into the water? Right, the problem came from them pouring things into the water, but even the way that it appears in media sends a message that immigration is at the heart of our issues. This is the sick rose that I was telling you about. Morning, evening. Your evening face. Not exactly, yeah, it's sort of like, it's a bit of a Walking Dead picture there. There's a reason for that. Cholera essentially helps you get rid of all the moisture in your body from every conceivable means of getting rid of moisture. All the ways. And the vomiting was often so violent that you broke capillaries beneath the skin, and people would sort of turn a bluish-green color, and it's not a nice way to die. Very similar to the symptoms of arsenic poisoning, actually. So much so that whenever cholera broke out anywhere, sometimes people's rich old relatives disappeared too, because they got sick. It was very difficult to tell if you'd been poisoned by arsenic or had died of cholera, and they actually started calling arsenic the inheritor's powder. I thought that was rather interesting. That's what it's doing to the insides of your body, ulcerating things. And so we know we need to stop it. Of course, not everybody died from cholera, but it did kill most of the people who got it. Who was more likely to perish from these diseases? If you were what? If you were poor? But why would that be? Why would that be? You're right, but why? Okay, partly it's an access to treatment issue. It's also, remember I told you that they were getting water from different parts of the lake? Right. So unfortunately, if you lived in the poorer areas, the access to water that you had might not be as good as if you lived further, next to a different pump station, for instance. Who else tends to perish from diseases like this?
Young.
The very young, yes. So infant mortality was incredibly high. And I am actually an 18th century scholar. Originally, now I've creeped into the 19th and 20th century. But a lot of people think that everybody died really, really young in the 18th century. How many of you think people died in their 40s and that was the average age? I set this question up wrong. Most people say, oh, people died when they were in their 30s and 40s. That's the median age. Actually, people lived to be 80 if you could make it past 5. The problem was so many people died young that once you average the ages, it actually brings the whole down. So 1904, water, deadly, don't drink it, very bad stuff. They decide, well, we need to get the water from further out. So several different times, they push the water intake further away from Cleveland. And this is a really, really interesting story, in my opinion, because again, the years matter. So 1904, they realize the water's deadly. They open a new crib. 1911, a bacteriologist who originally started in New York, where typhoid, and had lived through the era of Typhoid Mary. She was an asymptomatic case of typhoid, and she accidentally, not intentionally, carried it from house to house and gave a lot of people typhoid. And Mary was arrested and put away for this because they needed to stop her from contaminating people, and they just never let her out. So she died incarcerated. And that was really easy to do because Mary was an immigrant. Mary was Irish. And in essence, that's going to be the beat of this story, I'm afraid. But in 1911, bacteriologist Roger Griswold realizes that it's bacteria. He's looking at the water and he's going, oh, no, this is where it's at. This is the problem. And this is how I began to realize the connections between some of our criminal justice issues, forensics, and public health. There was evidence. He could show it to you right on a slide, right? Here's the bacteria that's causing us to get sick. In many of the early court cases, the forensic specialist I was looking at said, look, I can show it to you right here on this slide. It's human blood. This person must have committed the murder. But people didn't listen. People didn't listen. And it's not that people were foolish. It's just that that information was very new. These are still really new concepts, and people were not ready to accept them. So Perkins said, hey, I have an idea, filtration, chlorination. Let's, because we weren't filtering, not only were we not treating the sewage that's going into the lake, we didn't treat the water we got out of the lake. It went to a pump station and you drank it as if you just stuck your head over the edge of the boat. It is that water that you are drinking. And he says, let's bleach it, let's chlorinate it. In 1911, he gets his wish and they let him try it for 6 months and then they stopped the program. People thought it tasted funny. Consider what they're actually drinking. I'm not sure why chlorine was an issue. So they wanted to work on these problems. And in each case, they're like, okay, we just get cleaner water from further out, problem fixed. But the problem isn't fixed. You put something in the water, it doesn't just stay in one place. So what happens is the pollution begins to move, and that's where immigration becomes a big deal. In 1895, a city of 208,000 people produced 100 tons of solid waste. As late as 1914, 50 sewer lines pumped straight raw sewage into the Cuyahoga, just right into the Cuyahoga. And remember, in 1908, 300,000 people, and this is already the problems that we're having. We're about to triple the population and end up with 1 million people. And that's where you come to situations about population and prejudice. So we have proof. What causes people to get sick? Bacteria in the water. And we know that it's not actually caused by poor people. Poor people aren't causing it. Morals aren't causing it. But if you have some disease, and then you triple your population, and all of the reasons for that is because you've had an upsurgence of immigration, and now you have a lot of disease, what do you think people did? They didn't go, ooh, bacteria is bad. They said, immigrants are the problem. And so you had all of these newcomers, immigrants, minorities, and many of them very poor. They were coming here for a better life. They were not coming here as particularly wealthy or well off. And an unconscious prejudice already built on that earlier idea that you get sick because you're a bad person leads to basically a war on the other in Cleveland. Now, the kinds of, in the background picture here, and I'll have some other pictures to show too, the kinds of people who were coming here were mostly Eastern Europeans. We had Irish, we had Italian, and we had a very large population of Eastern Europeans. And these people, when they arrived, they were not considered native. They were considered other. They were not like other people. And in a way, that led to a lot of mistrust. So for instance, the Board of Health, which ought to be protecting us, ended up kind of a sanitary policeman. And they're looking in very specific quadrants for these problems. They're going to the poor neighborhoods, they're going to the immigrants, and there's some good stuff that happens, sure, but there's also some bad stuff that happens. There's a preoccupation with filth. Filth is an interesting word, isn't it? It doesn't just mean dirt. What else, if someone says that's just filthy? What are some of the other things that that means? What do you think? Yeah.
Immoral.
Immoral, yeah, filthy. That's just filth. They might be talking about pornography or something, right? They're attaching this word to people, and they're preoccupied with it. Frank Wells, Cleveland health officer, he did attribute high death rates, particularly of children, to poor sanitation. But he's one of the first ones who said, you know, maybe socioeconomics has something to do with this. And he did recognize that there was already a huge divide. People who were immigrants, who were poor, who lived in these shanty towns, they were working at lead smelting factories, that's really bad for you. Their children were dying in much greater numbers. There was overcrowding, there was poor ventilation, improper food, and not really good clothing and shelter. And largely, it was ignored in favor of focusing on filth. So, about 1870 to 1914 was the biggest immigration boom. Southern and Eastern Europeans, there was a shortage of land in their home countries, so many of them came here to escape persecutions and other things, and it becomes a boom town by 1922, 1 million people. 4 of 5 in Cleveland were either foreign-born or the children of foreign-born parents. There were people who didn't speak English, there were lots of miscommunications about things. And these are the bad houses that people were living in. That is just boards thrown together. And there's sort of, I don't know if you can kind of tell, there's like this just miasma, there's that word again. It's just smoggy. They lived in really poor areas. They frequently lived multiple families to a home. So what would happen is the homes that were actually in decent shape were originally single family homes. So they would turn them into 4-family homes that are really only conveniently situated for one family. Then they threw up houses. They literally just boards and nails together and created these places. They're next to the lead smelting factories. They're next to the iron works. They're next to the paint factories. This is a bad place to live. And you've got tons of people in these situations. Oh, let me show something else too, though. One of the things that tends to shock people when I give them a tour through the Dittrick and we cover the public health is I always say, this was a problem. These people were not considered white. They were sort of not white. They were other. They were non-native. And I almost always get someone say, but they're white. Look, they are. But of course, that's not about skin color, is it? This is about a construct of who deserves and who doesn't deserve, who's native and who's non-native, who's in and who's out. And so even though many of these people are Irish or Eastern European, or it might look pale, there's a question of not being one of us that is already present in all of these situations. Migration and immigration. Huge numbers of city workers are employed in factories. There's so many industrial accidents that, in fact, fake limb shops pop up all down Euclid Avenue. There's chronic exposure to toxic substances, poor ventilation in factories, illness, disease, and lead poisoning. We all know lead is terrible for you. We know it's bad for children. Literally, the parents of these children and some very young people who you might not normally think of being of age to work are working in lead smelting factories. That's what this is. This gentleman's not even wearing a shirt. He's just standing over open pits of lead. Lead gets into you. It gets in through your pores, and eventually it comes out in your gums. Your teeth will fall out. People get really ill. They die of various diseases as a result. So granted, I'm talking about mortality rates generally, but this trickles down, and unhealthy parents have unhealthy children, and the susceptible children are often the ones who perish. This is interesting. This is in the hall, or in the main gallery there. This is Dutch boy paint. Do you see this over here? That's a coloring book. That's a coloring book for kids, all about how lead is good for you and is your friend. And it's just like McDonald's, you know, it's like it's the prize that you got to help sell lead paint to people. They literally tried to attract young children, and we know that lead paint in homes is still a real problem around here, just as is unclean water. So geography and systems and mortality rates, how do all of these things work together to create problems of health and social justice? Well, they also create problems for justice in a more general way, which I'll get to in a minute. Yes, mortality rates were high. Most children died of diarrhea, dehydration problems from a variety of different diseases, but most of them were dying. They couldn't keep moisture into their bodies. They died of malnutrition as well, particularly among the offspring of immigrants of Southern and Eastern Europe. Bad housing and impure milk. By the way, you know how in old black and white movies, you get the milkman, and he's bringing milk, right? Where's he put it? On your porch. Are there lids? Is it summer? That's bad. So milk was often a problem. There's a really interesting, when they started the campaign about pure milk, they had a slogan. It said, "A fly in the milk is a baby in the grave." And they were really adamant about trying to teach people that impurities were leading to some of these diseases. The reason the babies died of dehydration and diarrhea was often stemming from impurities they had picked up elsewhere, not always disease, but sometimes food poisons through the food. The point. In spite of the progress, the Board of Health reported that expenditures for the city's health programs had not kept pace with those in other major U.S. cities. Dr. Ford, Secretary of the Board of Health, warned that since public health was a purchasable commodity, this is very important, Cleveland could determine its own death rate. If you're willing to spend the money, health is a purchasable commodity, and Cleveland could determine its own death rate. It doesn't get better, though. Unfortunately, things get a lot worse. It's not that they didn't have good ideas. The settlement houses, for one, were a very good idea, and they did help people. The Visiting Nurses Association, awesome. They went out and they treated babies and they treated people's illnesses. Public school sanitation and student hygiene becomes a big deal in the schools. Educational programs in the settlement houses and the nursing services. There's programs in child and maternal welfare, and they were working to control and prevent contagious diseases. That's good. It's not all good news. As always, we carry with us prejudice into every situation. By 1922, with our million-plus population, lots of good ideas are still being generated in the minds of people who have those same prejudices that they grew up with. The Visiting Nurses Association was very good. It was also a kind of spy organization in some ways. They were supposed to go find out why all these babies were dying. What was it about these families that made this happen? Very, very well-intentioned, but if you go in assuming if someone eats different food than you, or behaves differently than you, or parents differently than you, or has more kids than you do, and it's weird to you, you're automatically going to make a lot of assumptions about whether or not they are capable of taking care of their own children. And so you have this kind of understanding that somehow the system is going to be better at taking care of these children than their families, is built right in to early public health models. Other problems. Between 1920 and 1930, mortality rates declined for the general population. In the exact same period, they rose for African Americans by 15%. So you've got a 20% decline in the general population and a 15% rise among African Americans. And this is a huge deal. I want to go back in time for just a moment to that magical year of 1920, right before Prohibition kicks in. There was a crime wave in Cleveland, and this is part of my point about how public health and justice get connected. A crime wave, big crime wave. months before, and let's say, you know, a certain number of pages or inches were dedicated in the papers to crime. It jumps by 600% in the months that follow. It's just a ridiculous jump. And people start to worry. And there's town hall meetings. And people come out of the woodwork, and they're like, we need guns. This is true. This happened in 1920. We need guns. We need to protect ourselves from these criminals. They're everywhere. We don't know who they're going to hurt next. And we should get rid of due process of law. After Prohibition goes into effect, you've heard the term the usual suspects? What that means is they would just sweep in and arrest a bunch of immigrants. Lots of Italians, but immigrants in general, get them off the streets. This was their solution. It turns out Roscoe Pound, who is a jurist here, American jurist, considered the father of criminal justice in America, comes down here and does a Cleveland study in 8 volumes. And he looked at those newspaper headlines that jumped 600%. I might be getting that not exactly right, but it was a huge jump. And then he looked at the actual reported crimes. There were like 11 more crimes. It had been a manufactured crime wave that got people stirred up, and it pitted the sort of nativist idea against the immigrant. By the time you get to the 1930s and 40s, with the second wave of migration that happens after World War II, we sort of stop seeing so many people coming from European nations, actually during World War II. And instead, this workforce has to be supported by somebody, right? So they start bringing up and encouraging blacks to move north. And it was 10,000 before World War II and about 85,000 after World War II that were coming into the city. And if you think the problems of our earlier immigration wave went away, they didn't. It just got worse. But it was the same problems, really, but with a different group of people. They changed the names and the faces, but the problems that had been set in motion were still there. And there was increased discrimination and violence. There's probably nothing that proves this, I think, more readily than the tunnel disaster of 1914 here in Cleveland. So this was, I told you they needed clean water. They had to build further out. So they decided to build a tunnel 250 feet down that's actually under the lake and underground. And they're going out 5 miles. And it takes, sometimes you're in the dark for months. People would just work in shifts, and they would live out there on these weird platforms, isolated from everyone. Who do you think built the tunnels with all that excess of immigration? Immigrants built the tunnels. Polish people, largely. They called themselves sandhogs. They built the tunnel. They went out. Something went wrong. Safety protocols weren't followed. And the tunnel exploded. There was a methane gas leak. Many people died right there. The people who had actually initially ignored the safety protocols were part of the rescue mission. They tried to save people. More people went down and were not saved. They weren't sure what to do. They called Garrett Morgan. Garrett Morgan was a black inventor here in Cleveland who had built a prototype gas mask. So he turns up with his prototypes. He dons one. Other people get the other two. They go down and they rescue all of these people. When he came to the surface after rescuing all these people, they said to him, Cleveland, the city of Cleveland, will take care of you for the rest of your days. No. A few weeks later, they had the front page headline saying, heroes, heroes rescue everybody. Garrett Morgan's not mentioned. They heroized the people who had ignored the safety protocols in the first place, and then the city couldn't actually prosecute them. The city of Cleveland wouldn't even pay Garrett Morgan's hospital bill when he injured himself rescuing people. We didn't invent the racial prejudice problems that we have today. We've inherited them. But they haven't necessarily gotten better. They've just changed over time. Despite attempts at improved public access to health for minority groups, public health remained a kind of sanitary policing. Visiting nurses provided care, but were also supposed to report on these families to medical systems. This still happens. Many immigrant families who have moved to Cleveland, I just saw a really interesting talk at Drury University last week where they talk about families have children, they discipline them in a certain way, and then teachers were reporting them to child abuse for disciplining the way they've always disciplined forever in Syrian camps or other places. And that's the kind of thing that I'm talking about here. The very mission to assimilate these groups reinforced their status as other. The idea was, let's make them good white citizens. And new populations of others just inherited the problems and the infant mortality rates of the old. So what's that mean today? How do the beginnings of public health, police medicine, and immigration relate to today's infant mortality? Well, prejudice, conscious and unconscious influence systems. You don't have to know that it's a prejudice for it to influence systems. In fact, sometimes it's more dangerous when it's not recognized. The infrastructure of public health and medical care was built to keep both pathogens and people contained. Pathogens and people. The unhealthy environments and unsafe housing that plagued those early immigrants continue to affect minorities today. And in fact, some of these areas are literally the same areas. Yes, some of them have been gentrified and are fancy now, but some of the problem areas are still the problem areas and have always been the problem areas. So geography, sometimes referred to as redlining, geography matters. The idea of moral superiority as it relates to disease still haunts the rhetoric of care. I work for the British Medical Journal Group, which is a publisher, and I run the Medical Humanities Journal. I went to a conference in London a few weeks back, and they said, we want to partner with patients. I said, okay, tell me, what do you define as a patient? How are you constructing that? They're like, well, patients. We're gonna partner with them, and we're gonna let them give us their thoughts. And I was like, you realize by calling someone a patient, you're automatically setting up a relationship where someone has knowledge and someone doesn't have knowledge. You're automatically setting up these terms that mean something. And the same thing is happening here. This concept of moral superiority is deeply ingrained in so much of our health, in our care, in our public justice, in all sorts of ways. In Cleveland, but I mean, obviously elsewhere. So that's what gets us to our panel discussion today. I wanted to give you a sense that these problems are old. They're not new. They started when Cleveland had 1,100 people and got its first case of cholera. And now we're a booming city. We're a city on the rise in many ways, and that's great. How do we fix the problems we've inherited? How do we fix the problems that are still going on? How do we stop them from going on? And what does that mean, especially for infant mortality rates today? Because that's another problem that after all of our advances has not gone away. So I'd like to welcome our panelists and panel discussion. I'm going to hold our questions until the very end since we're going to do the discussion all at one time. So I'm going to have our panelists come up, share their slides. That'll be about 10 minutes per, and then we'll open this up to larger discussion.
Okay, so my name is Dana Langford. I am a certified nurse midwife, currently practicing at University Hospitals. I have been there in June. It will be 2 years. I am also the chair of McDonald House Maternal and Infant Mortality Committee. My experiences include practicing in Albany, Georgia, at a federally qualified health center, and St. Petersburg, Florida, also at a federally qualified health center. I was born and raised in Cleveland, moved away, and have now returned. So that's just a little bit about me. I practice in the Women's Health Center, which is in Rainbow, and it's going to be in that new big giant fancy building they're promoting down on 55th, and in the Richmond Medical Arts Building on Richmond Road. So did you know a majority of what composes our health really occurs outside of our provider's office? The last statistic that I read that related to this was 80%. So 80% of what we consider to be our health really has absolutely nothing to do with our health. So it's our socioeconomic status, our access to health care, our education, our insurance coverage, housing, levels of stress, and community health. I've highlighted the levels of stress because literally all of those fall under levels of stress. So if you're low socioeconomic status with no access to health care, you barely have a high school education, and you have basically Medicaid insurance or no insurance, because sometimes the stigma is the same for both. You are living in public housing. All of those things will lead to your level of stress. Or if you are African American with a higher socioeconomic status, you do have access to health care. You have a master's degree, a bachelor's degree or higher with private insurance, and you have good housing, you are still under a lot of stress. So that's that. And so this is just my experience. So the Rainbow Ambulatory Practice Clinic and the Women's Health Center, both at Rainbow, and are moving to the new center on 55th. They decided they wanted to do a big survey to really see what was happening in our clinics before we moved. So what they found is that nearly 50% of the patients expressed that their medical home should meet their community-based needs. So again, here we have all of our patients, and they have decided, you know what, it's great that you guys are giving us this health care, but that's not really what we want. What we want to know is that you guys are providing us with the necessary resources, that you guys are identifying community agencies to us to help us with these resources, that you're making the appointments for us, and that you're introducing us to individuals in the agencies. And then if those agencies don't respond, I need you to now step in and make sure that they do. And this is literally, I think that we have all experienced this as providers. This is what we experience when we walk into a patient's room. You haven't been making your appointments. No, I haven't. However, my food stamps are cut off. I don't have a car. And so now here's where I need you all to step in to help. So what that survey ended up telling us is that our patients have 31% in our RAP clinic, which is our pediatric clinic, and 31% in our women's health center, and the patients are basically the same. Have unstable housing or their housing is in poor conditions. They have financial shortfalls. They have inability to pay their bills. They have food insecurities, and they have other issues, including transportation and childcare. One of the biggest ones I think that really got a lot of our providers was I think it said 60% are concerned that they don't have enough money to make it to their next pay period. So I think a lot of the providers were overly concerned with that when that one came out. So here's the question at hand. Why, switching it now to why do we have this problem known as infant mortality? So with all that being said, now we have to find out, okay, so we've got all of these things, and why is it that we're seeing this huge influx, or now we're seeing this huge crisis, because this isn't an influx, it's always been going on, but here's why is this crisis happening? So First Year Cleveland, who I didn't even put statistics in this because I know she was gonna kill it with the statistics, with all the numbers and everything. First Year Cleveland told us, okay, here's what we know about Cuyahoga County, because Cuyahoga County is one of the worst in the country. Ohio is in the bottom 10 out of the 50 states in the country. Cuyahoga County is even worse than that. In Cuyahoga County, for every one white baby that dies, 7 black babies die. What that means, simply and very easily put, whenever I go into a room, if I deliver one white baby, I can expect that the next 7 black babies might die. It's very simple. And so we wanted to know why. So First Year Cleveland did all of their research, and they learned that the number one reason was extreme prematurity. So extreme prematurity is defined by the American College of Obstetrics and Gynecology as babies born before 28 weeks of pregnancy. So here's what we learned. We learned that African American, so what we do know in OB is that at 23 weeks, we will do everything in our power to save your baby if that's your desire. If you have a baby at 23 weeks and above, whatever you want us to do, we will do that to try to save your baby. 22 and 6, we will do nothing to try to save your baby, because what we know is that baby is non-viable outside of the womb. So extreme prematurity being 28 weeks. However, in Cuyahoga County, that extreme prematurity that we found the highest was at 22 weeks and less. So what we do know is that black women aren't even making it to 23 weeks to even make an attempt to try to save their babies. The other reasons are birth defects, which we had no control over, sleep-related deaths, which we did, infections, perinatal complications, and other medical causes. Last year, I believe it was 1 homicide, and then there was 1 case that was undetermined or still awaiting a ruling. So then State Bill 332 comes out, and that was a part of our new law that passed to help us figure everything out with infant mortality. And the state of Ohio got a nonprofit organization. Well, the state bill required that we get a nonprofit organization and contract them to issue a report in regards to social drivers of infant mortality. So they came with a new approach to reduce infant mortality and achieve equity was their policy that they came out with. And the policy recommendations for us were to improve housing, transportation, education, and employment. And the underlying drivers for those were poverty, racism, and discrimination. and trauma, violence, and toxic stress. I'm stressing that to you because while poverty is a huge one, what we know in Cuyahoga County is that those numbers for infant mortality go across the socioeconomic status line. It has nothing to do with your insurance. It has nothing to do with where you live. If you are an African American, point blank period, you are at risk. It does not matter about your socioeconomic status. And the reason that we're finding that is because of racism and discrimination and trauma, violence, and toxic stress. So in the March of Dimes came out with their report card in 2017 and gave us chastising and tapped us on the hand because our grade was a D for the premature rate. So 10.4% of our babies are born premature. In Cuyahoga County, that grade was an F. We were one of the worst in the country at 12.1%. But here's where it really kicked in for first year Cleveland, and this is Cuyahoga County. Black women in the state of Ohio have a 46% higher chance of having a preterm birth than all other women. And again, that's across the socioeconomic levels. So here to put it all together, what we do know is that one of the top reasons of infant mortality is extreme prematurity. And here we find that Black women have a 46% higher chance of having that prematurity, again, despite your socioeconomic status. So this is the latest report that came out from the Cuyahoga County Board of Health that basically said that for births 22 weeks or less by their race or ethnicity, African American women were at 82%. So last year in 2016, out of all the babies born 22 weeks or less, 82% of them were Black. So again, this goes back to what I was saying. At 23 weeks, we will do everything in our power to save your baby. Anything below 23 weeks, it's considered a non-viable pregnancy. So the director of First Year Cleveland, I was in a meeting one time and she said, let's at least get the babies to 23 weeks. And somebody in the meeting said, well, they're still premature at 23 weeks. She said, but at least we'll have a chance to save them at that point. We don't even have a chance to save these babies at all. So what is University Hospitals doing concerning this crisis? So we've started a maternal infant mortality committee, and that's the committee that I said that I was chair of. And there's a number of different things that we've decided that we want to do, and it's taken many different facets as it's come along. So since I've become chair, we have decided that we want to make this an action committee, and we want to actually get out in the community and do things to help. So the first one that we're doing is our community baby showers, which are going to be quarterly. Our first one was in March. What we do know is that if we connect people with the appropriate resources, it relieves their stress. So we had vendors available at the community baby shower, including a lot of the insurance companies. We had women in transition available. We had the midwives available, Birthing Beautiful Communities, which is a doula program in the city that focuses African American women, helping African American women. We also had exercising available. We gave away car seats, strollers, diapers, just connections. We wanted to focus on maternal stress. We had massage therapists come out and do massages for our women. So this is going to be a quarterly thing. Also, we've decided to take a focus on maternal mental health because what we know is that toxic stress is what's leading to those premature births. So a couple of us are going in May to the March for Moms. To March for Moms rally in Washington, D.C. And then also we've been collaborating with a group called Mom Power. We've started a recent group with them. And then 17-hydroxyprogesterone is a 17p injection. And that right there is basically if you've had one preterm delivery, it puts you at risk for the next preterm delivery. So we've been encouraging all women that have had that to get that. Centering Pregnancy is our group prenatal care. What we found with that is that if you attend Centering Pregnancy, it lowers African American women's chances of preterm birth by 42%. Postpartum LARCs is contraceptive placement postpartum, so right after you deliver. And Safe Sleep, we've partnered with Babies Need Boxes to provide safe sleep spaces for all of our babies. So here's the thing. I constantly hear that we victimize the victim. We constantly say, of course, these babies are dying. They're poor Black women. That's what happens. They don't go to their appointments. This is what happens when you don't care, and this is what happens. So this is a very good friend of mine that's actually an adult nurse practitioner that recently had a loss. And so I have decided that in order for us to make an impact, we have to start putting faces to this crisis. So she allowed me to actually share her story with you. So I'm just going to end with her story. I haven't edited or anything. I asked her to write it for me. She ended up calling me afterwards crying, like this was a lot harder than I thought. And this happened in 2016. So I'm going to end on that. On Thursday, March 26th of 2016, I miscarried at 17 weeks gestation. I did everything right. I started prenatal care right away at 7 weeks. I had a very good visit at my 13-week ultrasound. I didn't drink. No one around me smoked. And I don't work in an overly stressful environment. I will intercede there because I think it's funny she said that because at the time she would call us once a week venting, screaming, and yelling about work. And feeling like her supervisor was constantly over her shoulder and saying, okay, so now I'm going for drinks. So at the time, I worked in internal medicine in a private practice. It started with spotting at 15 weeks gestation, then my water broke 4 days later. I followed up with my OB, who then referred me to high-risk OB. At age 33, I didn't know why I needed a high-risk OB. The new OB told me that if I was unable to get my fluid levels back up, I would miscarry. The day I went to the hospital, I woke up having contractions. I went into labor and delivery, and I gave birth to my daughter. I requested genetic testing be done just so I could know what happened. A week later, I was told the results of the genetic test were normal. I'm usually a happy and fun person, but I went into a deep depression for a few months. I am lucky to have a very supportive husband and mother to help me through it, but it didn't matter. If the genetic tests were normal, then this miscarriage had to be my fault. It was something I did wrong. The guilt began to engulf me. Then I became angry at the women who have kids every year and then give it up simply because they don't want them. I became angry at all the crazy people that smoke and drink their entire pregnancy and have good outcomes. It was not right and it was not fair. I was angry, sad, felt guilty all at once for several weeks. I cried for weeks at night, but I had to carry on during the day and go to work as if everything was normal. When strangers would talk about their pregnancies or when I would see very pregnant women at Kroger, I would get sad and depressed all over again. This went on for months. Even after the tears stopped, 2 years later, I still blame myself and feel depressed all over again, and feel it must have been something I did or didn't do because of the miscarriage. I don't know that we as women ever stop blaming ourselves, and I'm still in fear that it will happen again the next time I get pregnant. Most days are good, but even now there are still days where I remember the pregnancy and the daughter whose cries and laughter I never got to hear. Thank you.
All right. And please just introduce yourself as you come up.
Hello, everyone. I'm going to try to breeze through some of this because I think Dana did a really good job of sharing some of the backdrop information. But my name is Erica Chambers, and I'm the Senior Program Director for Community Development and Health Equity for First Year Cleveland. All right. So I'm going to quickly give you what I hope to accomplish tonight while I'm speaking to you is to go over the overview of why First Year Cleveland was created, to tell you a little bit more about why infant mortality matters, and I think everyone up here so far has told you why it matters so much and the historical context behind why infant mortality matters, what our local and state data has told us, and based on that information, what we decided to do here with First Year Cleveland. So I'm going to go quickly through this now because I think you have enough backdrop about infant mortality. First Year Cleveland, I'm going to start with saying this. Ohio ranks 45th in the nation, 45th. She spoke about it being in the top 10, but we rank 45th in the nation in terms of infant mortality. Here in Cuyahoga County, our infant mortality rate now, as of 2015, was about 10.9. In Cleveland, the infant mortality rate was 13. The national average is 6. Our infant mortality rate in Cleveland with Black women is 16. So we have 10.9, 13, and then 16 when the national average is 6. So it was because of this that really served as a catalyst why civic leaders at the state and the local level said, you know what, you have to do something about this. They got together, 13 civic leaders got together, and they said we have to create a coordinated effort. We have a lot of different interventions, programs, initiatives going on across many different systems, but they are not aligned and coordinated. And because of that, we cannot clearly see what the heck is going on with our women and children. So First Year Cleveland, you will use data to align and coordinate all of these efforts across Cuyahoga County so we can begin to move that needle together. And so that is our role. Again, so when we went to speak back to the state because they gave us those scary numbers, we said, okay, so what's going on with the state? And they said, okay, yes, it's been scary, but over the past 30 years, we actually have seen a decline in infant mortality, 44% decline since 1980. But when we started to disaggregate that data, to look at it by race and demographics, we saw a different story. So over time, since 1980, we continue to see the plummeting of the white infant mortality rate. Is going down. Unfortunately, the top line that you see there is the black infant mortality rate, and it's been very unsteady, and it continues to be so, and it's been this way since 1980. In 1990, up until 1990, they weren't even classifying infant mortality by race. It was just either you were white or you were other. And so that's their best attempt of trying to adjust for the black infant mortality rate up until 1990, where you can really see what's happening. But this 1.95 and this 2.75 that you see here is actually talking about the ratio of white babies to black babies and how, in terms of infant mortality. Unfortunately, at the rate that we're going, we are seeing a 51% improvement in the white infant mortality rate, but it's happening a lot slower with the African American community. And as such, that disparity gap, as we refer to this invisible line that parallels these two numbers, is going to continue to increase. It's going to continue to increase. And at this rate, we will have to reach 2055 before we see a black infant mortality rate that's comparable right now to the infant mortality rate that we see in the white community. So it's pretty serious. Again, we asked them again, can we look at 2016? They say, okay, this is what it looks like. 5.8. Our healthy people goal for the national average is 6. We've reached that in the white community as of 2013. We have never reached any of our healthy people goals for the past 30 years in the black community. It's 3 times as high. This is currently today. As a result, because of this, we have an excess in death of black infant babies dying. This is the same data from 2016. Because our race, we have such a large gap in disparities between the black and white infant mortality rate. You can see here how many babies have died, 234 babies. And it's going to continue to be this way and continue to have more numbers grow if we don't really use the same approaches that we're using for white infants and their families with black infants. And Dana spoke to this, but I want to actually show you the storyboard that we created with that data. We said we wanted something that was really clear to show people what the statistics in Cuyahoga County were telling us and if they mirrored what we saw at the state level. And what we saw is yes. I'd like to draw your eyes to where it says babies not celebrating their first birthday there. That's 2016. 128 babies did not reach their first birthday. I think Dana also highlighted and she underscored that it wasn't social economic status. Initially, we thought, okay, well, this is women who don't have access to prenatal care, or they're low income, they're poor. But when we looked and broke out the data to look at the insurance coverage to the far right, it told us a different story. So there you can see that half of the women who lost their babies actually were covered by Medicaid. The other half were covered by private insurance. These are working middle class and upper middle class women who are losing their babies. I'd like to draw your attention to where it says prenatal care. We have some of the best healthcare system in the nation and in the world. Our women are pretty adherent. 70% of women who get pregnant in their first trimester actually go to the doctor to receive prenatal care. So we couldn't even blame it on that. The number was too high. Again, I think Dana emphasized when we actually broke out the numbers, you can see the majority of babies that died were born at 22 weeks or less, extreme prematurity. The other ones were due to birth defects and other malformations. And again, preventable seat-related infant deaths. We also wanted to disaggregate the data by race. Almost 65% of the babies that die here in Cuyahoga County are to African American women. They are to African American women. And this, again, was across all socioeconomic statuses. as was mentioned earlier. So why did we see this disparity? I know Professor Yerby is going to talk a lot about structural racism, so I'm not going to go over this in too much detail, but I'll simply just say over the past decade, we've seen a surge in research that's telling us for ethnic and minority communities here in the United States, you cannot talk about their lived experience without acknowledging the role of stress and trauma and the social constructs that have been created by the political and economic forces in this country. So we have a lot more research now that's saying that if you want to understand health disparities, you have to understand the constructs in which they've been created in this country, because they actually tell the entire story of what we're still seeing today. Again, I'll quickly breeze through this. For the African American community, my background's in human ecology and family science and public health. So you can't talk about lived experience without understanding the ecology or the genetic, biological, and social constructs that really tell the story of how people develop from birth to death. What this tells us is about the critical moments throughout our lifespan where not only do genetics and biology play a huge part in how we grow and develop, but at those critical points of development across the lifespan, social constructs have a profound impact on the way in which we develop. For African Americans, the majority of our experience, surprisingly to a lot of people, was really under slavery in the Jim Crow era. We very recently got into a space in our country where we have voting rights, educational rights, the opportunity to enter into traditional systems like the rest of the community. And these have sent the health trajectory for African Americans in a completely different context. So we can't talk about our experiences without understanding how these social constructs have drastically influenced the health disparities that you see today. In this case, it just so happens to be with the infants that you're seeing this play out. So with First Year Cleveland, I show this because it says we had a decision to make at the city and the county level and with the state. And they said, what are you going to do? We can't ignore this. You have to acknowledge it. So what are you going to do? And we said, when it's time for us to make our strategic plan, we have to make sure that people actually know and tell the story and tell the true narrative. And that's what we've decided to do. So our first goal under First Year Cleveland was to address the role of race in infant mortality. Our first goal is to reduce racial disparities, to improve birth outcomes here in Cuyahoga County. The second was to look at those other root causes of infant death, which I showed you before that we have control over. Some of those were due to things outside of our capacity. We couldn't do anything about it. But these two, addressing extreme prematurity, having a baby to survive past 22 weeks, and eliminating preventable sleep-related deaths, we felt like we could do something in those spaces. So I'll end here, but this is, we have a 3-year mobilization strategy. We engaged over 300 people, grassroots leaders, teachers, mothers and fathers who lost their children to really get their input to tell us, how can we really approach these issues? They said, then you have to be honest about the systems and the way that our city and our county is constructed, the political, economic, and social and cultural factors that really influence how we live in every day. So my goal and my job is to oversee these 3 action teams. I work with 11 action teams where we have different institutions who have expertise in these 3 strategic areas that I showed you before to really address some of these issues. We didn't want to hire a lot of people. We just took on the experts and said, we're going to align you, coordinate you, and support you with additional resources. But I oversee this part of the work around reducing racial disparities. My first action team is really working with the healthcare system leaders to explore implicit bias and structural racism within the system to see if we can create a coordinated effort to really look at this from a system-wide community perspective. The second action team is looking at infant loss. And the third action team is looking at the role of race and stress and how it impacts birth outcomes. We have experts from all different sectors here in Cuyahoga County who are working on this issue. And I will end there. So thank you.
Got your, here it is.
All right, welcome. My name is Rakaya Yerby, and I'm a professor at the law school and associate dean of institutional diversity and inclusiveness. And to ensure that we have enough time for questions, I'm going to limit my talk to about 5 minutes, and I'm going to focus particularly on racism in society. So I'm going to talk a little bit about the history of racism. So during the Jim Crow era, which lasted from 1877 to 1954, the federal government sponsored racially separate and unequal distribution of housing, education, employment, and healthcare. And what we see is that even after the Jim Crow era, which many say happened in 1954 with the Brown v. Board of Education, but it took many years for lots of the laws and policies to go into effect, that we still see racism in society. We see it at 3 different levels. I am going to focus particularly on structural racism and how it impacts women and access to income. And it really goes into power, the power used by the dominant group, and preventing the non-dominant group from having equal access and equity. So how does this play out? So you see the statistics up here on the slide. I'm going to give you some more. When we look at it based on age, it's different. And in fact, older women make less, which the first point notes. If you look at African American women physicians and surgeons, they make about 52 cents for every $1 than white male physicians and surgeons. And some argue that it's because African American women work less. But in comparison to Caucasian women, what we've seen, married African American women work about 200 more hours per year, 2 more hours so 200 more hours per year, 2 more weeks per year, 3 more hours per week, and make $3 less an hour than married Caucasian women, which is important for us because the laws on the books, Title VII of the Civil Rights Act of 1964, the Equal Pay Act, are all supposed to get at this, but we still have these disparities in place. So when we talk about racism, which I loved about your slide, right, it's a long history of it, and even when we have the laws in place to eradicate, to address racism, it still is there. So what impact does it have on health status? So when we think about it, African American women who had experienced racism and chosen not to object to it were 4.4 more times likely to have hypertension. The increased stress, also increased perceived racism affects African American women's rates of infant mortality. They did a research study. They had African American women, Caucasian women, and Afro-Caribbean women. Afro-Caribbean women's birth outcomes were very similar to the Caucasian women, but they followed them the longer they were here, the poorer their outcomes became. Why? Because they started having interactions with racism. And so I'm going to skip through the rest and really end on how do we address this problem. So we started off the discussion about public health and racism and how do we use our public health system to support the mothers, to provide clean water, to provide access that they need. What we need to do now in terms of the otherness and the issues along with infant mortality, we need to enforce the anti-discrimination laws. That would be the first step, right? Is that they're on the books, actually require people to pay people equal for the equal work that they are doing. And guess what? If they're working more, if they're providing more, pay them more, because then that means that they don't have to stress. They don't have to call you every week wondering why their supervisor is standing over them when they are working harder, longer, doing more, right? We need to integrate physical and mental health care. I can tell you, even when I go into healthcare, there's this disconnect about, I'll just give you a pill. I don't take pills. That's not really going to be the outcome that I need. I need an opportunity to talk with other people about my stress so that I can get it out, so that it is recognized, and so that I can find a way to be able to do that. And you can do that with community building groups is what I suggest, is that we actually work within the healthcare and provide ways for women to be able to talk about this, whether it's across races, whether it's across generations. So, sorry I rushed through, but I want lots of time for comments and questions for everyone. So thank you.